Hey, B.
Hi, Jen. Can I tell you about what I was thinking about on my way here?
Yes, please.
Okay. So it's fall, and it's so beautiful. And I was thinking how nature is such a beautiful teacher and how trees are such a parallel to a woman getting pregnant, and how you go from maybe a green tree to fall, the leaves change, you're changing, you're morphing into this like new thing. And then in the winter, how the leaves fall and how you have that baby. And then you're left kind of stripped and a little bare. But like the bones and the structure of the tree are still there. You can still see that it's strong. And then in the spring, how there's a rebirth.
Yeah.
And I was thinking that's so like similar to how this whole birth experience kind of goes.
The circle of life.
It's the circle of life. So I got this like amazing teaching on my way here by nature.
Yeah, all the leaves
Thank you.
finally like really come down today.
Oh yeah. It was
It's
like
windy.
Yes.
It's all like leaves flowing through the air. It's
totally.
beautiful.
It is beautiful. Anyways, that was my little
Thank you.
lesson.
That was a very beautiful way to start the show. All right. So today's topic, when we were thinking about doing the podcast, I kind of envisioned it as us answering questions that I get from patients. So we're going to talk about shivering.
Yeah.
And this is something that can happen to anyone who's having a baby.
Yep.
Actually, you know, I love percentages.
I do.
And I tried to find a nice solid percentage for this.
Could you find one?
It drove me insane because each article I read or each source gave me such a wildly different answer that I just got so frustrated and I give up. It's anywhere from like 20 to 80%, but it depends on this, but it depends on that. And so I'm not even, sorry, I don't have a percentage. I'm not going to give it. It's something that happens. Just, that's all I'm going to tell you.
This is a moment for you, Jen.
It might happen a lot. It may not happen a lot. I don't know. But if it does happen to you, or if it did happen to you and you're still curious about it, I'm going to tell you about it.
Yeah. I'm actually very, very curious to hear about it because I too had it.
You did?
And I also witnessed it. And in the moment, like the rationale is hard to explain to a patient going through it because you immediately kind of see that wave of fear come over them when it feels like already you've given up your body and this like whole birthing moment, and then to have something layered on top that wasn't expected at all, maybe nobody talked to you about, it definitely invokes a sense of fear. I literally see their face expression change.
Oh, yeah. So do you want to talk about your experience first?
Okay, well, mine was after birth.
Yeah.
Mine was when I was at home recovering. And mine specifically was because, and we might be going off a little bit before we get back to where you want to be.
Is this the only time you experienced it?
It's only happened to me once. And it was because I had a rectal enema. And the response that my body had afterwards was uncontrollably shaking. And it scared me, but it really scared my husband because he had no clue what was going on. And now we're in our home environment. So it's not even like he can ask a nurse or a doctor what's going on. He's just watching this happen to me. And luckily my mom was there. So she was like, it's okay. Her body has just been through so much.
Yeah.
Which is true. It was like almost like a shock to my system. And you know, the nurse when she gave it to me at discharge said you might shake a little bit afterwards, but I didn't anticipate it to be a full blown.
So I didn't plan on talking about rectal enemas today.
But that's how
there are a lot of things that can cause shivering.
A fluid shift. Okay. Well, that was my experience with it. But I will say in the hospital.
But not in the hospital. Not like immediately.
Right. The experience that I witnessed with patients was usually it occurred after the delivery of the placenta.
Mm-hmm. Yes. So I've seen it 100 million times. And let's start with how this can happen to anyone, whether you have a vaginal birth or a C-section, whether you have anesthesia or don't have anesthesia, it can actually happen to anyone. It's part of the birth process. Yeah. And there's so many different things that can cause it. So I'll try to like go through all of the different
I'm sorry. I'm laughing because I know I just really threw you off.
You really did. Like, I was not.
I'm so sorry.
Expecting rectal enema to come up like 3 minutes in.
I mean, okay.
But thank you for sharing.
You're welcome.
I always appreciate a Bethany story, no matter what. I really am thrown off.
I will stay on track.
I'm so
sorry.
thrown off. But the most common time for it to happen is after delivery, like immediately after delivery. And it usually can last like up to 1 hour. And so let's say, to take away some of the factors, which would be anesthesia, let's say you don't have an epidural, you just have a vaginal delivery. And after you have the baby, people can get some shivering.
Yep.
And shivering, just to define it a little bit more, it's, uncontrollable shaking, involuntary contraction of a lot of your muscles in your body. Yeah. And your body is doing that for a reason. Anytime we're shivering, it's to generate heat production. So obviously, when you're cold, you shiver, and that's to bring your body temperature up if you're cold. Also, if you get really sick and you have like the chills, that's your body wanting to generate heat, aka a fever, to fight off an infection, right? So why does it happen if you don't have anesthesia? It has to do with all these hormones, everything that happens after birth. Of course. The placenta separation, we can blame for a lot of things. I mean, that's a huge change to our physiology. We had this organ and now we don't. And
I think about how incredible that is that first a human is birthed, or humans are birthed, and then an organ is birthed. And it is a very wild concept to think about. So of course, you're going to have a response. Your body's going to have a response to this. Like, it's two major things are being expelled from your body.
Yeah, it's wild.
It is.
And also, obviously, you bleed after delivery. You're losing the heat along with the blood loss. So part of it could be just that you're really actually cold. So why could you be cold? Well, if you're in a hospital and the room is cold, if you're getting IV fluids, which you definitely will in a C-section, and you may be getting IV fluids during labor, even if you have a vaginal delivery, those IV fluids are not the same temperature as your own blood. So it's going to lower your body temperature. So even though it can happen without anesthesia, it's more common with someone who, let's stick with vaginal delivery, who has an epidural, because there's aspects of the anesthetic itself that reduces your body temperature, makes you more prone to shivering. But then it's even more common with C-sections, which is why it's a relevant topic for our podcast. So how common? I don't know. I'll just tell you, when I'm talking to patients, let's say who are coming in for a planned C-section, and I'm going through, I think, a pretty detailed, this is what's going to happen to you.
Is this conversation before or in the ER?
In the OR.
Oh, sorry. OR, sorry.
Before.
Okay.
Like when I'm having consent signed.
Got it. Okay.
And I usually talk about risks, and I talk about side effects and just in general what's going to happen. You're going to come into the room, you're going to step on the bed, blah, blah, blah. But for example, I will bring up nausea as something that can happen. And, I say, let me know if you start to feel it so I can try to help you with it if you do experience it. But anyways, I don't bring up shivering.
Why?
Because it's not that common in my experience with a planned C-section, or it's not that bothersome that I see. But I just wanted to compare this to when I'm taking someone back for a C-section who has been laboring.
Okay.
So if they've been laboring, they may already be like shivery, shaky from before the epidural and then after an epidural. And I'm assuming that they have an epidural, by the way. And now for some reason, unexpectedly, they have to go back for a C-section.
Right.
Those people, I tell them, you will shake.
Yeah. Okay.
You will.
Okay. And
I mean, I guess not everybody does, but I feel like pretty much everybody does. And so I really stress that. I say, you're going to get shivery. And it has to do with, I think, a few different aspects. One is there is generally more stress and anxiety in that type of situation. And when we talk about shaking, shivering, I'm shaking in my boots, I'm scared. Like, there's a reason that phrase. So, I mean, that is a small part of it, but for sure that's going to be worse, probably if this is unexpected or emergent or scary and something has gone awry and now you're going to have a C-section. It's also the medication that we give through the epidural for C-sections, which is lidocaine. It's different than what we give for spinals.
Okay.
So I think the medication itself also makes shivering much more likely.
So we have lidocaine to blame.
Partially, among other things.
It's nice to blame something.
Yeah. Always blame anesthesia. Don't you know that rule? It's always our fault. So I tell every single patient, listen, you're going to start shivering. It's probably going to be annoying. It's not harmful per se. And it will go away eventually, I promise. And
do they ever ask if it's affecting the baby?
Probably. I mean, the shivering?
Yeah, I don't know. I mean, I just think it's like once your body's going through something, I think when you're in that moment, I think for me, I would feel like, is this, like what's happening to me, is this affecting the baby?
Yeah, probably. I get that question about nearly anything, like, will it affect the baby? And the answer is generally no. I mean, listen, shivering is not great if it's excessive, besides being an annoyance, because it is kind of increasing your body's like metabolic rate.
Right. It's doing it for a reason.
Well, they're not that smart because
okay.
So you're supposed to shiver for a reason, aka being cold, but something happens with the anesthesia where you may actually not be as cold as you normally would be to cause shivering. Your shivering threshold decreases. Basically, you shiver sooner than you would normally. Okay, so I tell everybody that they're going to shiver, and then they start shivering, and then they look at me, and I'm like, I told you. Like, they forgot already.
Which is, I think, a very normal thing in that situation. If information is being given to you, but it's not being absorbed.
How could you? You've just been told that you unexpectedly are having a C-section. You have all these things coming at you. And I just gently remind, it's okay. It's okay. I basically do it all over again.
And I think it's probably good for their support person to hear that as well, because that's a scary thing to see when...
It is. I was going to bring that up. Yes. So when it happens, we talked about fear and anxiety, but a lot of times, even if this happens with like a less chaotic situation, let's say a planned C-section, moms will look at me and they'll be like, I swear I'm not nervous, or I'm not this nervous. I don't know what is going on. I promise you I'm not. And I'm like, I know this is not, you're not
in control.
So I could contribute to it, but I don't think it's a huge part of it. And the partner will come in and they will also look at me and be like, what is wrong with her? Why is she freaking out? Why, they see nervousness.
Of course.
Or they think that she's really cold, and really neither may necessarily be the case. So you can shiver even if you're not technically cold. You don't feel cold. You may not feel cold because if you have an anesthetic numbing the lower half of your body, remember, one of the ways that I test to make sure that the spinal is working everybody listen to episode 2 because it's one of my favorites and it's like our least popular episode, but is using cold sensation. So you lose that cold sensation. So you probably aren't going to feel cold even if you are. But you may be a little cold. Your body temperature is a little lower than normal because, okay, the room might be cold, the IV fluids, you have an open surgery.
Right.
So your body is losing heat through that big open incision. Normally your skin is protecting you from that. So you...
I didn't even think about that, but like, hello.
Yeah.
Like that totally makes sense.
Yeah. And then the anesthesia itself. So again, one of the reasons why you get a lower blood pressure with a spinal or an epidural is that the blood vessels in that part of your body that are numbed become dilated. Your heat will be like redistributed from your core to your periphery, and you're going to lose heat. So you do lose heat because of the anesthetic, bottom line.
Okay.
And then also your threshold for shivering is going down.
Okay.
So between the two of them, plus the type of medication, it's just like a lot of things.
So it's not an adverse reaction. It's an expected response to the medication when you see a patient
Definitely
shivering.
for the lidocaine.
Okay.
And either way, if you experience shivering, I'm not concerned.
Right. And it doesn't, how long would you say it normally would last for? A couple minutes?
No, it's usually longer than that.
Okay.
So I would say like up to an hour.
Okay.
It depends how severe. I feel so bad for people when they are really, really shaking and they're probably going to shake like that for the rest of the surgery.
Okay.
So I said that I don't generally bring it up for a planned C-section just because I think when it does happen, it's not as bad.
Right.
And it's just not as common with a planned C-section. People will tell me, let's say their first C-section was an emergency. Now they're just coming back for a planned C-section. And I'll say, is there anything about your first C-section that I should know about?
Yeah.
And I'll ask specifically, were you very nauseous? How was your pain control afterwards? But they will say to me, I was shaking so badly and it was awful. And will that happen to me again? And my response is usually, it's much less likely. It might still happen again, but it almost certainly won't be as bad as it was the first time because it's so different when you're in labor and all of the multitude of things that are happening during labor and the medication, et cetera, et cetera. So what can we do to prevent the shivering? One factor we can control is the actual body temperature as far as, like the temperature of the room and keeping the patient warm, even if that's not going to totally fix it. We have these forced air warmers that we put underneath patients, right? It like blows hot air and it goes under your whole body. And that can keep you warmer. Yeah. We warm IV fluids, which is such a nice thing to do. If you're going to get a whole bunch of IV fluids, wouldn't it be nice for them to be warm? Yeah. You feel like the cold going into your IV. Yeah. And what else can we do? So just pre-warming. So before you even get cold, making sure that your body temperature is kind of warmer. Yeah. They've looked at a couple of different medications, one of which is Zofran. That I give anyway.
Right, for the nausea.
For nausea, it's been looked at for preventing that big drop in blood pressure or the drop in heart rate that you can get after spinal anesthesia. So I'm moving towards giving it sooner rather than later. I think it can help prevent a few things, but it's not like fully...
Makes me love Zofran even more.
No, they literally, if you look at studies, pick a problem and they've thrown Zofran at it to see if it can fix it. It's so funny. But, maybe. Yeah. And when you're looking at a medication that's generally pretty safe, people get it for nausea, for many things during pregnancy, during labor, after birth, whatever. I usually put a warm blanket over mom's arms.
Remember that warm blanket. Also the weight of the blanket.
Yes.
I think that if you are shivering, it feels like someone's like giving you a hug. That blanket is like calming you a bit more. And
Yes.
that's super helpful.
Take a nice folded up warm blanket out of the warmer and kind of drape it over the arms.
Yeah.
And we talked about shivering being very uncomfortable, but it's also interrupting bonding with the baby. How are you supposed to, if you're allowed, you know, if you're able to have that experience where you can hold the baby, do skin to skin in the OR, that's obviously going to impact your ability to do that.
So when my friend was telling me, when I was asking her, like, what topic would you like us to talk about?
Yeah.
And shivering was one of the first things she brought up to me. And the reason, well, one, she didn't expect it. And she had tried to vaginally deliver and then ended up in an emergency C-section. So she was like that perfect classic case. But so she said the two things that bothered her the most about it, one was that the nurses were then holding her arms down, and that feeling of being constrained really threw her off. And then I guess it was either, it must have been
why were they doing that? Do you know?
I mean, I think for safety measures for her. No? Okay.
What safety what?
Well, I guess.
She's going to like punch herself in the face.
I don't know. Everybody might shiver a little bit different. Maybe it's like this. And you're like, I don't know. Tell me why,
I'll tell you why.
Please tell me why. Don't let me guess.
Because it interferes with the monitors.
Oh, well, okay. Hello. Yeah, thank you.
So primarily, you know, I guess if you're like really moving around, it might affect your EKG reading, but it's basically the blood pressure cuff.
Okay. Yeah, makes sense.
And yeah, so I actually have in the past, when I have patients coming from labor, tried to put their blood pressure cuff on their leg, knowing that this was going to be an issue and not wanting to have to, because I don't want to have to hold their arm down. Right. And also it's annoying for me because I'm not able to get an accurate blood pressure reading because your muscles are like going crazy and it just like gets confused. Like it tries to squeeze and it's interfering. It can't get a blood pressure reading. And so I really do have to like put like one arm, you know, like blood pressure cuff here and put and like hold and I'm like, I'm so sorry. I just want to get, you know, one accurate reading because that's just like a really important thing to know when you're having a C-section. Right. It's going to tell us, you know, how your anesthesia is going and if you're having more blood loss than expected.
So I was right. It is about safety.
Yeah.
Just not how I was thinking about it in my head.
It brings up the whole arm strap thing, which I could talk about all day long, how it's so unfair and traumatizing to strap anyone's arms down.
Well, that's how she felt. She felt like it was very... Yeah. Like, obviously, now we know the rationale for why it was being done.
Yeah, and of course, I always explain that.
Right. I don't think somebody explained it to her. And it was just this forceful feeling. And then they were, like, trying to put the baby next to her face. And she's like, I can't even... Yeah. I can't even have this moment right now because I'm in fear and I'm feeling really out of control with the movement of my body right now, and I don't think anybody talked her through it.
Yeah. So normally I check the blood pressure every 3 minutes because I'm crazy and I just like to know. But in that situation, if I know that everything is going fine, which there's a lot of different ways, you know, I can look at what's happening in the surgery, then I spread it out to 5 minutes and I don't go crazy with it if I know that they're fine because I know how annoying it is and how uncomfortable it is to have to hold the arm down like that. But that's one of the reasons. And then were you about to say something else?
Oh, I said the two things are one, that was obviously uncomfortable having two different people holding her arms down, but the inability to bond with the baby because she wasn't able to process both things that were happening.
Yeah, and she didn't even have an arm to just at least go up and like touch.
touch
the baby at all.
Right.
So, yeah.
So going back to for sure impacts that bonding moment immediately after birth when that is happening.
Yeah, and I read something about maybe making pain worse. I don't know because if it's over by the time your anesthesia has worn off, I can't really imagine, but. I guess if your anesthesia is worn off and you're shaking, that probably would not be very comfortable.
No. So is there a medication that you can give to help
Yes.
decrease the amount of shivering?
Yes. So if you are already shivering, there are medications that you can give.
Okay.
There are 2 of them. One of the newer ones that has just been studied is Anesthetics.
Okay.
The other one is Demerol, which is, that's kind of the older one. Both of them have side effects.
Which
Sedation, let's call it sedation for both of them. And also blood pressure changes, which is what really worries, I think, anesthesiologists.
Right.
And, that's why people aren't kind of jumping to treat it. But they're really small doses, like so small that these side effects, I think, are very minimal. I mean, according to the studies, there aren't really side effects.
Okay.
So it's always, when you can treat something, but then you're worried about what's the medication going to do as far as side effect profile, people are hesitant to try it when it's new.
Right. Of course.
And again, this is thinking about if it's not harmful, right? If the shivering, shaking is just an annoyance, and it's just interfering with the bonding of a baby. In medicine, we tend to not care as much, right? Than something that's affecting the blood pressure, right? Which is a more medical problem, which is obviously important. But
even thinking about it from a patient's perspective, if I'm thinking about the safety of myself versus maybe that immediate bonding, I don't know.
I don't know. I'm trying to think if I would want the medication, and I think...
Did you experience it?
No.
Okay.
No. But I think I would want it.
The medicine.
Yeah. And me as the provider, as the anesthesiologist who, obsesses over blood pressure measurements, I would be a little scared to give it. But I have friends who are OB anesthesiologists who give it all the time. And they're like, oh, it's amazing. It helps them so much. You don't have to worry about the blood pressure. It's fine.
Yeah.
So I need to start giving it more, basically. It's the moral of the story. If I can find that medication, not all places have that medication. It's like a kind of expensive medication. And not necessarily widely available.
So it decreases it. It doesn't stop the shivering.
I think it really, really helps it.
Okay.
Yeah. So you can ask if you experience this, and just know that there are some options. And I think this is going to be something that we're going to see people using more and more.
Yeah.
And recognizing that even though it's not truly harmful, it is harmful if it's affecting,
emotionally harmful.
And the people literally coming back after their birth 2 years ago and talking about it.
Oh yeah, no, she still talks about it.
Yeah.
That's why she was like, you have to talk about the shivering in the OR.
Yeah.
She's like, nobody talks to me about it.
Yeah.
So when you see a patient shivering in the OR, now, you had said before, like sometimes you're the person who brings the baby over to mom. Does this completely change now your focus of the patient? Like that's when we talk about the supportive person also in the OR. So you're now able to only focus on the situation going on with the patient, and somebody else is facilitating bringing the baby over to the mom.
Well, can she even hold the baby if she's shivering so much?
No, I don't think so. That's what I'm saying. Having that person who's bringing at least the baby over so that the mom can see the baby.
Yeah, I'm not usually the one that like picks the baby up.
No, I know that, but you said before, like sometimes you're the one who will...
I'm helping mom hold the baby.
Yeah.
Yeah, you're right. I mean, if I'm holding her arm down for a blood pressure monitoring, then that would be not helpful.
Right.
But I think it's a combination of, can she even do it?
Right.
I mean, I always try.
Right.
I say, how are you feeling? Let's see. Sometimes if nervousness is a part of it, then once they do see the baby, it goes away a little sometimes, just enough. And you for sure, if you're shivering, you're going to need more than one person probably helping you. So whatever nurse brought over the baby, if you have a partner there, they're going to be probably staying there more on top of you. If you are able to hold the baby a little bit despite the shivering, than if you weren't shivering.
Right.
Yeah, for sure. you need more support in that case.
Yeah.
Yeah. So that's that. You're right.
I was treating like a full circle
Trying to think
of
of, like,
bringing back to like when we were talking about
having a doula or having an extra support person.
Exactly. That you see the benefits, you know, in situations like that. Obviously, don't know how the patient is going to react until it's happening, and the value of having that additional person in the room to help facilitate these.
Yeah. Yeah. And remember, your blood pressure cuff is only on one arm.
Right.
So I think I'm usually only holding one arm down. So if the other one can be giving a little snuggle, then it's not totally prohibitive of you being able to do that. If, you know, it's harder to do. It requires more support.
If more women were informed prior to even in that moment of a consent, you know, again, we talked a lot about how information is digested so differently when you're in that setting than if you're hearing it. You know, way ahead of time, and you're like, oh, okay, this might be something. It also gives you the tools to be asking your OB, what can we do to mitigate this?
Yeah, ask your anesthesiologist.
Okay, your anesthesiologist. You know, I think that I didn't really think about it in the OR because I never was in the OR until I was a patient in the OR, but I definitely saw it in both natural and vaginal births with epidurals, that it was so common after the placenta was delivered.
Yeah.
And sometimes it would last a little bit, and sometimes it would probably last maybe up to an hour.
Yeah. It's like a few minutes to up to an hour if it's just purely that post-birth shivers.
But then knowing that time frame, I think, is also a healthy thing. So if you are experiencing it, like anything, if we can wrap our brains around knowing, okay, this might be a couple minutes or it might be an hour versus is this ever going to stop? You know, and that's when I feel like the fear takes over, when you feel like this present moment that you're in, you're not going to be out of it. Yeah. And it's hard to see yourself getting out of it until you are, you know.
Yeah. I usually tell people it's by the time we're rolling out of the operating room, for sure you're going to be feeling better. I don't usually see this being a huge problem in the recovery room. Yeah. It's mostly an in the OR type of thing. And if you think about it, you know, we talked about how the first part of the C-section, from starting the surgery to getting to the baby, is usually shorter than the second part, which is like closing everything back together. Right. And so during that part, just the time from delivery is number one, and it's time from your anesthesia. It's slowly wearing off, and as it wears off, and as the time passes from when your baby was born, all those things are going in favor of the shivers going away finally. Yeah. I always feel so bad.
So it will end.
It will end.
I think it's a short term.
And forgive us if we have to hold down your arm.
I know. And maybe it's like anything. If maybe they had just said to her, we're going to have to hold down your arms versus just holding down her arms.
No, I literally profusely apologized. Right. I'm like, I am so sorry.
You just need to clone yourself, Jen. You really do.
Because, I mean, I have to hold it a little. It's like, it's not even just a gentle hold. Like, you have to, like.
It's a forceful hold.
Yeah, because I'm trying to literally. Stop. Like, it's hard. Like.
I'm sure.
I feel so bad.
Yeah. But just saying that, empathizing, even though you didn't experience it, just hearing somebody say, I know this is uncomfortable, that automatically makes you feel like you're a patient who's being cared about right now.
Yeah.
Oh, no.
Yeah. And so if anyone's had an anesthesiologist put a blood pressure cuff on your leg,
that's the reason why.
That's really great. Yeah.
Yeah.
Sometimes you just don't have time. Yeah. Or depending on, honestly, just the way your operating room is set up, if it's not long enough, or there's various reasons why that may or may not work. We've talked about before putting other monitors lower down. You could technically put the pulse ox on your toe. Right. You could technically put the blood pressure on your leg. Yeah. But then if there is a problem with it, you don't have access to it, which is the issue. Yeah. And also the readings are not exactly the same blood pressure wise from your leg and your arm. So it's more accurate on your arm, but better than no accurate readings, which sometimes even with holding down the arm,
you're still not getting inaccurate.
It's such a struggle. Yeah. And so you're trying to just look at everything else that's going on to make sure that everything is good. But blood pressure is that one thing that really really when it's nice and normal, you can feel good. You know, also you don't want high blood pressure and then we're worried about preeclampsia, et cetera, et cetera.
Can I ask you a question? How do you keep yourself calm in the OR? I don't know why I keep saying ER. OR, so sorry.
How do I keep myself calm? It's just literally my job is to be calm.
Right.
Like that is the whole thing is being calm in emergency.
I mean, I think that's so
situations.
amazing because I think that's a really hard.
Oh, it took some time.
Yeah. No, you're not telling yourself a mantra.
It's just, no, I don't do anything like that. It's just doing things over and over and over again. And, you know, the most seasoned anesthesiologists are the most calm. Not all. Some people are just, they're just not calm people and they get a little fired up.
Yeah.
But as long as you're clear-headed and able to make decisions quickly, you know.
I mean, I'm asking like from a
And be
patient's
prepared.
perspective, you know, like when things are going.
Oh, I try to appear as calm as possible, even if I'm not calm in my head.
Okay.
Because I think that's important.
Yes.
And I don't know if calm is the right word. It's, you know, if I'm worried, concerned, doesn't necessarily mean that I am whatever the opposite of calm is. Like,
Not calm.
but
Hyper.
but I obviously like get concerned sometimes.
Yeah.
And I try not to totally show that. I'm just moving a little quicker.
Okay.
And I already have this all in the back of my head. Like, I'm going to do this, if this, this, if this, this, if this. And then I just start moving towards those steps. And
that's comforting to know as a patient that you have all of these backup tools. Because I think that's what makes it very scary in the OR is you're giving everything over to make sure that these providers are taking care of you at the highest level. And that's why I was just curious to know.
yeah. So I hope I show calm on my face even when I'm concerned. I don't know that I always do, but I try.
Yeah.
Because I do think
Well, you also have your
I'm
mask
trying
on.
to.
So
Oh,
you
yeah,
could
that's
be me.
helpful. It's really helpful.
And you have kind eyes. So if they're just looking at your kind eyes versus your maybe.
Yeah. And then, you know, I'm turning around and setting things up and getting things ready if I'm feeling like whatever, something different than the usual needs to be done. But I try to portray a sense of calm as much as possible because it's just not helping anyone to be all worked up.
Right.
And of course, you know, we are the ones taking care of you. And so we are the ones making the decisions and moving forward to treat whatever is going wrong. I assume that's what we're talking about. If something's going wrong, if nothing's going wrong, I'm like, I just am legit calm. Like I'm just loving it, you know?
Yeah, I know you are.
I just like, great. I'm just talking and seeing a birth and that is like riding a bike, like a normal standard, typical C-section is just super easy, run of the mill for me. I'm not even thinking, basically.
But I feel like that feels good as a patient to know that it just feels like this is so normal for you. And I think sometimes as a patient, it's hard to understand how normal it is for the medical team because it feels so abnormal for you as the patient.
Yeah, and we're so conditioned. Like I was describing how I know if something is going wrong. And I just have this routine of, you know, looking at the patient, looking at the monitor, looking at the surgery. And I just
This
know.
triangle effect.
Yeah, and I can just, you know, first of all, the monitor makes noises and there's certain alarms and things. But in general, it's just doing that survey over and over again. And any one of those things changing brings up a little alarm bell. And then I go through, you know, what it could be. And it's just like a little, I don't know.
A little circuit in your head that you're going through.
And anything that looks different or, you know, when you do it all the time, I think anytime you're just doing something a lot, then you become more attuned to anything that's different, right? So I can even, although I have no idea how to do the actual surgery of a C-section, I look at it and I just know when something doesn't look right before they even, ideally they tell me, but I don't know. How do you say it? I get like piqued or like my interest is piqued if I see something that's different, and then I start looking at the patient and monitor a little more carefully and know when I'm going to put in a second IV or call for a certain medication or give a certain medication, and I'm kind of at the ready because I'm so used to seeing normal. And so I can see, when there's variations from normal, basically. Yeah,
just the value of working as a team.
But looking at normal is just another day.
Just another day for you, Jen. I mean, it really is just, I hope you like sometimes really have a moment to appreciate how amazing what you do is, and how, I don't. I think you should though, because you have no idea. I mean, even just in our conversations, the comfort and the peace and this that you bring to patients that I don't think you probably take a moment to recognize that you're doing. And I know your practice has shifted after you've become a mom, but I think even before then, you practiced in a way that helped patients not experience maybe a traumatic feeling because of how you were as a provider. I think that's a gift. No, you have such a gift. Thank you for your gift.
I like talking to you. It makes me feel good about myself.
Thank you for your gift of what you're doing for women. So nice. It's amazing. It really is.
It's nice to hear stuff like that because it keeps you going,
Yeah. And always.
Wanting to, we're trying to make differences here too. People who are not my patients, but my own patients are so important.
I feel like people are going to want you as they're like, where do you work? I'm going to go to that hospital. If I could redo it, I would definitely want to know what hospital you work at. I'd be like, I will be there, and I'm going to let you know the day I'm delivering, and you better be there too.
Well, there are people at my hospital who
I'm sure
I've gotten requests before.
But that's also the best compliment from other doctors and nurses and midwives and doulas to be like, please, can you be here when I'm going to be delivering my baby? That's the ultimate compliment.
Well, it's a mutual. I like them. They like me.
Yeah.
It's nice.
Yeah.
Ideal.
Yeah. Ready to wrap it up?
Yeah, let's go.
Okay. All right. So it's been a little while since we've done a traditional mantra. So I thought today we should do one.
Okay.
Of course, I'm going to pull out
what do you have
something.
In that pocket there? It's a perfect pocket for...
I do love overalls because it's a 2-for-1 outfit and you have lots of pockets. So I'm going to have you hold your heart rose quartz.
Okay.
And
should I
you can
just hold it any which way?
Yeah, you can hold it however you want. So we're going to do things in threes today. So first, you're going to hold that.
Got it.
Second, we're going to be adding some music to the mantra today. And okay. And then you're going to repeat after me. You're going to close your eyes.
Okay.
And then we're going to say this 3 times together. My greatest reward is to bring you into this world.
My greatest reward is to bring you into this world.
My truth might be best said in tears.
My truth might be best said in tears.
My therapy is to know fear is temporary.
My therapy is to know fear is temporary.
My greatest reward is to bring you into this world.
My greatest reward is to bring you into this world.
My truth might be best said in tears.
My truth might be best said in tears.
My therapy is to know fear is temporary.
My therapy is to know fear is temporary.
My greatest reward is to bring you into this world.
My greatest reward is to bring you into this world.
My truth might be best said in tears.
My truth might be best said in tears.
My therapy is to know fear is temporary.
My therapy is to know fear is temporary.
Namaste.
Namaste. 3 times.
You did it.
Thought we were done after the second.
No, and I knew 3 for you would be a lot, which is why I purposely did it today for you, Jen, because sometimes you do have to say things to ourselves a couple times to truly absorb it.
Yeah, I actually did get it a little better the 3rd time.
The 3rd, yeah.
Yeah.
Next week I might make you do a 4. Oh, I'm just kidding. Thank you so much for joining us today.
Yes, please reach out to us. We'd love to hear from you. We've gotten a few people message us, and it just literally makes our days, our weeks to hear from you.
Goosebumps all over when we get these messages, knowing we're making a difference for you.
Yeah, and we want to know, which episodes you're enjoying. Yeah. Don't tell us the ones you don't enjoy.
If you don't have something nice, don't say it.
We're trying different vibes with each episode. Yeah. So if there's anything in particular that you like, maybe we can do more of them. Yeah. And follow us on Instagram.
Yes.
The CSX podcast is our handle.
Yes.
And now you can email us. We have a new email, hi@csxpodcast.com.
Yeah. Yeah.
And I think we have a website.
Yeah. Our website is about to be going live too, which we're super excited about. So you can reach us and get some blog posts, and some more information will be on our website, or a little more bios about us. Yeah.
There's more content coming out for you.
Yes.
So always. That's csxpodcast.com.
Yep.
All right.
Bye.
Bye.